Welcome to the Explainer. Today, we're demystifying a procedure that honestly can look a little intimidating at first glance, but is actually a beautifully structured, incredibly vital ritual of care. We are talking about tracheostomy care and suctioning. You see, this isn't just about managing pieces of plastic, it's about mastering a process that ensures a patient's safety, their comfort, and literally their ability to breathe. Whether you're stepping up to the bedside for the very first time, or you're just looking to sharpen your clinical edge, we're going to break this down so you know exactly what to do.
Okay, let's dive into this. We're taking an anatomy to action roadmap today. First, what is a tracheostomy? Then, 2, anatomy of the tube. 3, routine care steps. And 4, safe suctioning. After that, we'll look at 5, lifespan and home care. And finally, 6, handling emergencies.
Before we even think about touching any equipment, we need to set our baseline. Section 1. What is a tracheostomy? Let's get that foundational knowledge.
So simply put, a tracheostomy is a surgical opening made right into the trachea, your windpipe, just below the larynx. An indwelling tube goes right into that opening to create a super reliable artificial airway, mostly for patients needing long-term support. But here's the absolute most important takeaway from this whole concept. Because this tube completely bypasses the upper airway's natural filtration system, the nose and mouth, the patient loses their natural defense against inhaled bugs. That means your skilled, strictly sterile care becomes their literal shield against serious infections like pneumonia.
That brings us perfectly to our next segment, Section 2, anatomy of the tube. Let's do a quick equipment overview. Every standard tracheostomy tube has a few absolute must-haves. First up is the outer cannula. That's the main body that actually sits inside the trachea. Then we have the inner cannula, which slides right inside the outer one. This piece is a real game changer because it's specifically designed to pop out for daily cleaning, which we'll cover in a second. You've also got the flange, which is that flat plate resting against the patient's neck, giving us a spot to secure everything. And finally, the 15mm termination. That's a universal size, meaning it fits seamlessly onto standard ventilators or respiratory gear.
Now, depending on what the patient needs, these tubes can have some pretty fascinating optional features. Take the inflatable cuff, for instance. It's this tiny balloon that inflates to anchor the tube and create a maximum airway seal. Absolutely crucial for patients on mechanical vents. You might also spot a fenestration, which is basically a specialized hole on the curve of the tube to boost airflow, or even a speaking valve. These are incredible because they let air pass back up through the vocal cords when the patient exhales, making speech and swallowing possible again. Now that we know our way around the hardware, let's talk maintenance. Section 3, routine tracheostomy care steps. We are laser-focused on patency and cleanliness here.
Phase 1 is all about prep and removal. After checking their ID and doing strict hand hygiene, you'll want to assist the patient into a semi-Fowler's position. This just really helps promote lung expansion. But here is a vital, non-negotiable step. Explain everything you are doing. Even if your patient can't speak, establish a simple communication method, like a blink or raising a finger. It empowers them and offers huge reassurance during a really vulnerable moment. Once they're settled, gently unlock and pull out that inner cannula, following its natural curve, and drop it straight into a soaking solution to break up any gunk.
Next, grab a sterile brush moistened with saline and give the entire lumen a good scrub. Hold it right up to the light at eye level to make sure it is perfectly clear. Now check out this very specific drying technique. You use a folded pipe cleaner, yes, literally just like the craft supply, only sterile, and you dry only the inside of the cannula. Why? Because leaving a tiny film of moisture on the outside acts as a natural lubricant, so it just glides right back into the outer cannula without any friction when you lock it back in.
Phase 3 shifts our attention to the stoma site itself. You'll clean the incision area with sterile applicators dipped in normal saline. Remember, 1 swipe per applicator so we aren't cross-contaminating anything. Then, carefully slide a V-shaped sterile dressing right up under the flange. The whole goal here is to support the tube securely without causing a bunch of clumsy movement that could irritate the patient's skin.
And this brilliantly illustrates the 2 ways to secure the tube, the 2-strip method versus the 1-strip method. But honestly, no matter which one you use, the golden rule is exactly the same. The square knot must always go on the side of the patient's neck, never the back. You do not want them lying on a knot and getting a pressure sore. And always double-check that you've got enough slack to slide 2 fingers underneath the ties. We want it secure for sure, but we can't interfere with their circulation.
Let's see how all this builds into our next core skill. Section 4, safe and effective suctioning, effective clearing. Before you do anything else, you have to dial in your suction pressure.
For adults, standard agency policy is typically between 100 and 120 millimeters of mercury. Now, for infants, it's going to be way lower, around 50 to 95. And remember, before you even think about introducing that catheter, you've got to prepare the patient by hyperventilating their lungs with 100% oxygen using a resuscitation bag.
The physical motion of suctioning really requires a deft touch. You gently insert the catheter about 5 inches, but, and this is huge, you do not apply suction yet. Now, pay close attention to step 2. Pull back 1 to 2 centimeters before hitting the suction. Why? Because you absolutely do not want that powerful suction grabbing and tearing the delicate mucous membranes of the trachea. Once you're pulled back a bit, apply suction for 5 to 10 seconds while twirling the catheter on the way out to minimize trauma. Always give them 2 to 3 minutes to catch their breath and re-oxygenate between passes.
Routine care isn't a one-size-fits-all deal. Section 5, Lifespan and Home Care. Let's look at how we tweak this based on who the patient is. Working with an active child or infant is a completely different ballgame. You usually need an assistant just to gently hold them still during care, so a sudden wiggle doesn't accidentally pop the tube right out. Contrast that with elderly patients. With them, your focus shifts heavily to skin integrity. Elderly skin can be as fragile as tissue paper, meaning your stomach care needs to be incredibly meticulous and gentle to prevent rapid breakdown.
For folks transitioning to home care, education is literally everything. Caregivers have to master cleaning that inner cannula 2 to 3 times a day. But here is a massive pro tip to pass along: hydration. Tell them that keeping the patient super hydrated actually thins out those secretions, making them so much easier for the patient to just cough up naturally or way easier for the caregiver to suction. And of course, they need to stay hypervigilant for any signs of infection, like weird odors or a sudden fever.
We've covered the routine day-to-day stuff, but clinical reality isn't always routine, right? Let's pivot to the high-stakes side of things. Section 6, Handling Tracheostomy Emergencies, Rapid Responses.
Okay, what if the tube falls out? This is it. This is the scenario that spikes the blood pressure of new clinicians and home caregivers more than anything else. What do you actually do? Step 1, and I know it sounds cliche, but it's critical: stay calm. Because here is the secret. If that tube has been in place for more than 5 days, the surgical tract is fully established. It is not going to just magically snap shut on you. You have time. Reassure the patient, tell them to just breathe normally right through the stoma, and immediately call for backup. If you have a tracheal dilator handy, use it to hold the stoma open, and whatever happens, do not leave that patient's side while waiting for the response team.
Another major red flag is acute dyspnea, basically sudden, terrifying breathing difficulty. You've got to troubleshoot this fast, step by step. First, just ask the patient for a really strong cough. If that doesn't pop the blockage out, pull the inner cannula immediately. Honestly, most of the time the sticky gunk is trapped right in there, and pulling it fixes the problem instantly. If they're still struggling, go in and suction the lower airway. If all 3 of those fail, hit the alarm for help and get some low-concentration oxygen on them fast.
Finally, if the absolute worst-case scenario unfolds and the patient goes into cardiopulmonary arrest, your CPR protocol needs a few major tweaks. Expose the neck completely, but hear me on this: absolutely do not pull out that outer tracheostomy tube. You do not want to lose your established airway. Just pull the inner cannula to make sure it's clear, and then hook the ambu bag directly onto the tracheostomy tube to ventilate them.
So, the crucial point is this. We've spent this explainer diving into millimeters of mercury, square knots, and sterile fields, but we can never lose sight of the big picture here. Behind every single one of these strict, rigid steps is a human being who is relying 100% on your expertise for their most basic, vital human need: oxygen.
How will mastering these structured rituals transform your confidence the next time you step up to a patient's bedside? Tracheostomy care is so much more than a checklist. It's a profound responsibility. When you flip your mindset from anxiety to having total step-by-step clarity, you change the game for your patients. Thank you so much for joining me on The Explainer today. Take all of this, visualize the steps, and go bring that brand new confidence into your clinical practice. See you next time.